Welcome to ChiroSphere, where we talk about all things chiropractic and some things not so chiropractic. I'm Dr. Ray Foxworth, your host for ChiroSphere and CEO of ChiroHealth USA, the network that works for chiropractic. Today's guest is making an impact from the clinic to the national stage. Dr. Kris Anderson is a doctor of chiropractic, certified strength and conditioning specialist, and holds a Master of Science in clinical research. Beyond the clinic, Dr. Anderson serves as the president of the American Chiropractic Association and advises the American Medical Association's Relative Value Update Committee, which plays a key role in shaping healthcare at the national level. And quite frankly, it's how our services end up being valued. So, yay, Kris. He's also a past member of the Clinical Compass, the immediate past president of the North Dakota Chiropractic Association, and a former Chiropractor of the Year, reflecting his commitment to advancing care and collaboration across the profession. Dr. Anderson, I'm really excited to have you with us today. I appreciate you taking the time to spend a little some of your insight and wisdom and what's going on in the background with the ACA. So, welcome, sir.
Yeah, Ray, thanks so much for having me. Like I mentioned to you as we got started here, I'm a listener too of the podcast, so really excited to be a guest as well. So thanks for having me.
You bet. Well, thanks for being a listener. I didn't know that. That's always good to hear. So you've balanced clinical practice, research, and national leadership. What's the why behind your decision to be so involved?
That's a great question. It does drive me. I think the why, and it's this need to help make sure that our patients get the care they need. It ultimately, every success I've had as a leader in the profession and in the clinic is focused on patients. And so I think because our profession does such a good job of focusing on patients, that's where we can have success. And historically, I've always thought that as a profession, we have a compelling story. We see the miracles that happen in our clinics that we don't really know how to explain, and inevitably we come up with reasons why and try to explain how. But what we're finding now more and more in research is the reason why is becoming more apparent, and it does have to do with what we do. There is an active ingredient in the spinal manipulation, the chiropractic manipulation, the adjustment, and so at this point, it's really about advocating for that, not just trying to tell our story, but really helping people understand there's a lot of great science supporting what we do now, and that more people should have access to what we do.
Yeah. Do you feel like that what chiropractic has espoused for the 100+ years? We had a lot of different explanations along the way of what was happening and what was working, what's not. Um, do you feel like that we're kind of being vindicated with the research that's coming out, saying, "See, we told you so," or is there more research that says, "Oh, that's not quite right, guys. It's really this." Well, what's your perspective on that? Because I know you're involved with the Clinical Compass, and you guys delve into that stuff.
We do. I mentioned the active ingredient part, and that sort of speaks to the efficacy of spinal manipulation in particular, the adjustment. I'm not sure exactly that we know yet, if we're being vindicated, as you mentioned, with the story that we've shared over the an evolving history. But I think what we do know is that the patients, again, back to patients, they have a much better opportunity to get a good outcome and especially avoid those negative outcomes when they go to see their their chiropractor first. And that, when we have the tools available to us to help people, work through, really debilitating issues in their life and come through on the other side without the risks of unnecessary drugs or surgeries and things like that. And, I think for me, it's not so much that we've nailed down and been vindicated with, this is exactly how this happens, but I think our outcomes, our effectiveness has been shown in the research, and that's, really what the Clinical Compass does well with their clinical practice guidelines that they're publishing. And I'm very fortunate to be part of some of those, is that we can show that there's a path forward to get good outcomes and especially avoid those unnecessary risks.
Yeah. What I have always found interesting is, there's so many different ways of treating patients, but for whatever reason, a lot of our profession seems to get good outcomes despite the variability in the approaches. You've been involved with the clinical compass, and I'm going to ask you, how important is it for chiropractic to have more standardized clinical pathways? And the reason I'm asking that question is it is such a luck of the draw for a patient when they go to what would be the old yellow pages or even social media now to be able to go from one chiropractor to another. We all hear the stories. Well, they didn't do anything like that, or he does this entirely different. While that's nice to have some diversity, the reality is it's not really a clinical pathway. We don't have consistency among clinics, and it's really difficult for the general public to know who to go see. I even have a hard time if I'm trying to refer a patient to another state. I've got to go look up and see what they do because I want it to be close to what I'm doing. So, what's the benefit of the clinical pathways, and how do we get more people to understand that it's not telling you what to do, but it is just a pathway?
You know, but there's a lot of, I have a lot of thoughts on that. One of the things that as I was a leader in my state association, I was proud of being able to do was when we travel from where I live in Grand Forks to Bismarck to the Capitol and talking to our different agencies and legislators, it's a 4-hour drive, and there's a lot of mileage there that we get a chance to stop and say hi to some of the members of our state association. Uh, and so that was, I think, the most eye-opening experience to me is that you really don't know what happens in another practice unless you've been in that practice. And I think for you and what you do with Chiro Health, you have a notion, I guess, of what might be happening behind the scenes for your team when they're working closely with the clinic. But ultimately, it is really hard to know what you can expect to get when you go to a specific clinic. And I struggle in the same way to be able to make a referral that I trust when someone might be in another state or even in another town in my own state. Sometimes it's challenging. Um, I think the main thing that I I am kind of shifting towards is, and this comes from one of the Whedon studies that compared, chiropractic services for a frontline treatment of low back pain versus an opioid. And what they found was the number needed to treat in that study, off the top of my head, is something like between 6 or 7 visits. So you avoid an adverse event from an opioid just by diverting 7 people away and having them see the chiropractor first. And the reason I think that's important is because that study can't discern from the Medicare database, which chiropractor is a good one, if you want to classify it like that. And so in reality, I think the thing I know is that the biggest value add for the patients we see isn't that they need to find a good chiropractor. It's that they need to find any chiropractor because your risks just go exponentially up if you go somewhere else first.
Yep.
And so for me, my leadership role with the ACA, I want to refocus our attention to the broader profession and the understanding that we really need to be advocating for the profession wherever we are. And as you mentioned, I'm in the room with the AMA 3 times a year and calls about valuing our services across healthcare. And so in a room like that, it's about advocating for the profession and not so much suggesting that, well, if you find a good one, then you can get a good outcome. The data show that anybody that's participating in Medicare should be able to deliver a better outcome than someone who's going somewhere that's giving them a prescription that they don't need. So, I've really, and I don't know the best way to, like you mentioned, find that good one, find someone that you can refer to. The standardization of our delivery of care, that part is where I think Clinical Compass really excels. And if we can do a better job of helping the profession more broadly understand how to implement and use the clinical practice guidelines to our benefit, because like I mentioned before, we've had a compelling story for 130 years, and now we have a lot of great data to support what we do. And it's adopting those guidelines that support what we do, and especially in favor of some other guidelines that are, for whatever reason, not supportive. And there are instances where they're not supportive because they chose to ignore certain things when they developed the guideline, and they're not very friendly to what we do. And there's definitely bias still across medicine, more broadly against our profession. But it's when we show up and show them what we can do, and then adopt the specific guidelines that really demonstrate how effective we can be. That as a profession, I think we can move more towards not standardizing exactly what technique you use or exactly how, but more in the way of, this is a baseline assessment. We're gonna treat for a period of time that's defined or outlined in these guidelines, and then we're going to measure their outcomes in a consistent way that's reliable. And that, I think, is that would take a lot. But again, it doesn't dive into the technique specific stuff and tell you exactly how to deliver the care. But it also requires that we participate to some extent in the broader delivery system.
I'm old enough to where I can remember when the Mercy guidelines came out, and some of us called it, the "Oh, have mercy" guidelines. And at that particular stage in my life, I actually had a network here in the state of Mississippi. We were the chiropractic network for the state health plan, 195,000 covered lives, and that's a whole different world. So, where do you see the biggest gap today between evidence-based care and what's actually happening in practice?
Biggest gap, I think the main thing that I see as a barrier is where we're included and where we're excluded by policy. So obviously with the ACA, we've been pushing on Medicare modernization for almost a decade, and really trying to break through that barrier to make sure that, not that we have more, but that we just are treated fairly with everyone else. So I think that plays a big role. We also, we didn't mention this initially, but I'm in clinical practice full time, but I split my time between my private practice, where I work with my wife, who's also a chiropractor, and then also the federally qualified health center locally, Spectre Health. So I've been working with them part time for the last 8 years. And what I see clinically there is being able to integrate with the EMR Epic. So everyone's heard of Epic, but using Epic compared to using the EMR I have in my practice is just night and day different. And it's not so much the documentation, it's the communication. So my ability to communicate with everyone else on my patient's healthcare team is facilitated by Epic. I can just dive into their note, I can send a message, I can send an email, it attaches their information, and we can hone in on specific things, and it's all protected. And I have that ability to do the same thing in my private practice. So, being integrated and being able to communicate effectively, just trying to get chart notes out to other, treating providers. If I'm in my private clinic, it's still based a lot of times on faxes if I don't have a personal relationship, or we're just trying to send text messages if it's someone I do happen to know. So, the biggest barriers still remain the policy limitations that prevent our profession from participating in new care models, and then also the technological barriers, because we just remain isolated and we don't have the ability to communicate effectively with the rest of the healthcare team when we're only in our private practice and our systems don't communicate outside our four walls.
Something I've observed over the years. I'll go back to the when the Mercy guidelines came out, and everyone looked at that document as, oh my God, they're telling us what to do. They're placing limitations on us. Well, I was the owner of a chiropractic network here in Mississippi, 195,000 covered lives with a state health plan, and we had to do utilization review. And what was interesting, Chris, was uh, while a lot of docs may feel like that guidelines and recommendations for treatment are trying to dictate how you practice, the reality is, even going back to the Mercy guidelines, if you understood them, you had absolutely no problem making the argument for your care. But there's just that initial resistance to being told what to do, and I guess we're all a bunch of renegades as chiropractors anyway, but, what I have found is if you do understand the guidelines, that you actually can use that to your advantage. It's also can come into play in malpractice. If you're just willy-nilly out doing all kind of different things and there's this thing called the standard of care, and I think that'd be kind of hard to define within chiropractic, but there's really a lot of benefits to at least knowing what the guidelines are, and then I'll ask the question when a doc's giving pushback about that, that if you were, I hate the analogy, but if you were an auto mechanic and you've been used to working on an engine and doing A, B, C, D, but this other guy found a better way to do it or a little bit better and the car ran better, would you not want to take advantage of that? And so, I wish we had a little bit different perception of clinical guidelines, evidence-based guidelines, evidence-informed. So there's a whole conversation that really needs to happen around that rather than just, kill it first and ask questions later. It's just been interesting to watch over the years.
There's definitely some bad guidelines out there. And to your point, I had experience in our state with the workers' compensation program, which is a state agency. They're not allowed to change policy without the legislature, but what they can do is operate pilot programs. When my background in research, I think of a specific thing when I hear the word pilot. And of course, at the state level here, they just call it whatever they want, a pilot, and it becomes a pilot because they said so. So, we had the experience of having our care limited to a lot of pre-authorization. This goes back, almost, 8 or 9 years even. And we sat in a room with them, and they quoted the guidelines that they've adopted that are very common across the country, and certain states adopt them for the specific workers' compensation programs. And the person in the room on their side of the table quoted the guidelines that we're only allowed 6 visits. And because I knew the guidelines, I was able to point to the guideline and say, actually, what you're quoting is spinal manipulation. Chiropractic is a profession. You can't limit us strictly to what is defined for spinal manipulation only. And because we knew that in the room and were able to counter the way they were misusing that guideline, we were actually successful in getting equity with our visit number before authorization were required with physical therapy for injured workers. So even if you don't like the guideline, definitely get to know it because it might be the case that you have an opportunity to advocate for the profession, for your patients, so they can get the visits they need, if you realize people are using it incorrectly.
So, I've heard that whenever new research comes out, that there's a time lag of, and the numbers I've heard have been like, it takes 17 years for research that's done today to actually reach the front lines. And that's not just in chiropractic. I mean, that's across the board. So for a chiropractor that's not historically been involved in reading research, where where would you where would you steer them to start begin to understand the research, the benefit of the research, and how it can help them improve their outcomes? What's the source?
I think, obviously having been on the board for Clinical Compass and participating in guideline production with that group, I think they just set the standard for the profession, especially in the U.S., where we bring in the expertise of so many people through the Delphi panel process and get their input on how the guideline is developed, and then we use the best evidence available to support the recommendations. So clinically, I think that's the best place to start is just with the practice guideline. And it's not so much that you're being told what to do by the guideline, but that you're given the parameters of what's most common. But there's a huge list of other complicating factors that exist in the guidelines as well, and they help, I think, tell the clinical story for the patients who fall outside of what's normal, and they have these other complicating factors, and by making sure you're documenting that correctly, you can support a longer treatment plan if that's the main gripe that people have about there's a visit limit on the from the clinical practice guidelines. I think just understanding all the complicating factors, doing a very thorough history and evaluation, you can cultivate those complicating factors, document them, and then it does support a much longer treatment plan than you may have thought was supported by the guideline if you just went straight to the table. It says, 3 times a week for, 2 or 3 weeks and then tapering. So understanding the guidelines, I think, is the best place to start. If you're a practice that treats a unique patient population, then you're going to have trouble just working from a single guideline like that. But you might be able to dive into some of the source information that was used to develop the guideline to further understand your specific needs in your clinic. But the clinical practice guidelines or best practices documents, I think, are the best place to start if you've never gotten into research before. And you don't necessarily have to read the whole paper. I know one of our papers was maybe 30 pages, and it's dense science and a lot of citations. And if nothing else, just go to the tables. If you look through the tables in a clinical practice guideline, you're going to get a lot of useful clinical information that you can apply in your practice right away.
Yeah. So for those that aren't familiar with the Clinical Compass, an amazing group of people that dedicate their time. I mean, they're not paid positions, not not that I'm aware of. I'm proud to say our company has supported Clinical Compass for a number of years as a vendor member, um, and I know along the way that it's almost like the Ghostbusters theme. Who you going to call? So I know there's been several situations where the who you're going to call ends up being the clinical compass when there's been some bad science or bad guidelines or things that we need to address that are put out by others. So, um, what are a couple of the wins that come to mind that as a result of the clinical compass getting involved, we've been able to change policy or change the level of care? Anything you can share with us?
Yeah, a couple things that are top of mind for me. I know, and this goes back almost 10 years now when United Healthcare changed their policy around headache care. And
Wonderful.
there was a large movement from a lot of the organizations in the profession to sit and meet with them and feature the type of science that the Clinical Compass is able to produce in support of treatment of headaches. And so that was a great example of the profession coming together, supported by the science from Clinical Compass, and being able to overturn that policy that eventually or effectively would have harmed patients had it been implemented, because it, when you have a headache, you need some sort of an option, and when you eliminate the conservative options, then you're left with much riskier options, despite whether or not you can demonstrate the efficacy of the specific treatment. Having conservative options is just really critical. I had also the unique experience in my state. One of our plans decided to eliminate the benefit for pediatric patients, and that this would have been any patient under 1 year of age. And they actually used in support of that decision a practice guideline that I was an author on. And so, as I mentioned before, when you know the information and then you see it being misused, it's a great experience to be able to intervene and say, I don't think you're using this correctly, and can we talk about it? And ultimately, as I mentioned with UHC, this was a conversation that we had with their leadership, and in our state, this was a conversation that we had with the leadership of the health plan, because we already had a relationship with them, and we did actually bring in an expert author who's on the scientific commission with Clinical Compass to help guide that discussion. It was sort of a challenging position for me personally to be an author on a paper that I thought they were misusing, and then trying to tell them that, well, actually, you're wrong about this. So we were able to successfully have a really good discussion, and in that case, it was the best practices guide, or it's not a guideline, but the best practices paper for pediatrics that they adopted then and used when they were uh, considering that benefit. That's the expectation they have for that type of treatment, and so we were able to restore that benefit without much disruption in our practices.
I hope docs are reading between the lines here. It's a clinical compass that kind of synthesizes the information and the research that's out there and helps us develop practice parameters or whatever term you're comfortable using. Um, but it really upstream, what's important is that we do have more research. And I hear people all the time say, oh, we've got more research that supports what we do than we've ever had before. Yeah, but it evolves and things change. And it really is. If you didn't have that information readily available in your memory, you couldn't fight those battles. Otherwise, you're just reliant on their interpretation of it. And a lot of times they're not aware of the research that has been done on what we do, or they take what they've got and they misapply it. So, I guess the battle cry is don't hesitate to fund research, and then because that research can be used by groups like the Clinical Compass to actually defend what we do and to justify what we do. So embrace it, docs. Well, hang tight, everybody, while we take a quick break to hear from our sponsors. Welcome back to our podcast with Dr. Kris Anderson, president of the ACA. Again, thanks for joining me. I know you got your plate full at the moment. Probably not at just this moment, but probably for the last 20 years, right? 30? So as
Yeah, it's been a
president,
journey, that's for sure.
as president of the ACA, what are the biggest priorities you're focused on right now?
Obviously, as I mentioned before, the Medicare modernization of chiropractic coverage is critical for the profession in so many ways. And internally we have what's now kind of an infamous slide from our senior VP, John Filardo, and it covers everything that Medicare touches. And it's not just I want to get paid for exams and X-rays and therapies. The Medicare program is an important part of a lot of, or almost all of, the other federal programs that exist. And so modernizing Medicare so that we're acknowledged to our full physician status without those limitations just to the spinal adjustment gives us an opportunity as a profession to really mature and grow in other ways. And from my experience in the health center, for instance, I'm limited to what I can do as an administrator in that facility. So if I were to be the chief medical officer, for instance, that's a limitation currently within Medicare that prevents some of that. And being able to get funded through other programs in the federal government for services in the health center would, be a benefit as well. And so what we have right now is a unique opportunity with the current administration because they're focused on health in different ways than administrations in the past have engaged with health, and especially policy. And what we're benefiting from now is the ACA is participating in a lot of different discussions within the profession that we've haven't participated in as much in the recent past. And because we're becoming more and more aligned around what's needed for the profession, we're able to engage with the MAHA community and the things that they're trying to build out for our profession and ask for specific things that we know can help our patients because they remove these additional administrative barriers that the profession faces. So, at this point, for those who may not or may know, I don't know, but without getting too deep in the weeds, there are provisions of the Affordable Care Act, 2706 in particular, that have to do with healthcare equity and being treated similarly or the same as the rest of our healthcare peers. And that's a provision that hasn't been implemented from our perspective with the original intent. And we're engaged in discussion from the whole profession in a way to hopefully affect change on some of these different administrative policies. There are other details as well that may not be that interesting and may get pretty deep into the weeds, but the opportunity to have these discussions with the administration and ask them to affect some change here that would remove the barriers and allow us possibly to make referrals and order within the Medicare program and do some of these other pretty simple, what seem like simple things, but they create significant burdens for the profession because we're not able to participate in a lot of different care delivery models. And so outside of just modernizing Medicare and the legislation that we're trying to advocate for with Congress, we have a unique opportunity with the administration now to ask for some of these uh, specific things in statute that we hope they can change without having to go through Congress. And it's a great opportunity that we're now all working together to advocate for those.
And it is much appreciated. For those that don't know, there's a level of cooperation and conversations occurring with ACA and ICA to get to one bill, as it's been talked about an awful lot, which hopefully increases our chances of getting something passed. And for those docs that think, "Oh, I don't want to deal with Medicare," well, it's only the single largest payer in the United States. Okay, and so when you're looking at patient population, you might want to consider seeing them. The frustration is that we're so limited in what we can do. And we've all heard the saying, as Medicare goes, so goes the rest of the world. Well, this is an opportunity for us to change that and to be able to have parity in reimbursement and eliminate some of these artificial barriers to care, like the pre-cert, like the automatic cap on visits on chiropractic and not on PT. There's a lot of leveling of the playing field, I think, that will trickle down, if you will, if we can get this passed, because people look at Medicare as the way to handle chiropractic, and nothing could be further from the truth. If we could get them to understand that what we do and how it impacts patient outcomes, and even on the prevention or wellness side, you know, Medicare does pay for wellness care. It pays for an annual visit to my doc for just to get a checkup. And yet we have to beat our heads against the wall to get, 6, 12, 18 visits or whatever it might be under that particular plan. And so it is the Medicare bill is not just about Medicare. It literally has a trickle down effect on just about every other payer system out there, I would think.
Yeah, that's absolutely true. And the ACA's had a bill in Congress. This is, I think, the fourth Congress in a row. And as it stands currently, we have over 152 co-sponsors on the House bill, and that's carried by Representative Stubbe from Florida, but the chairman of the Ways and Means Committee, which is the committee of jurisdiction here, the most important committee when it comes to Medicare. We have a really strong advocate in Chairman Smith, who used to be our primary sponsor before he became chairman. And then in the Senate side, we have the exact same language. The Senate bill is S-106, and the House bill is H.R. 539. My senator from North Dakota, Senator Kevin Kramer, is the primary sponsor on the Senate companion bill. You know, it, it's it's one of those things that we continue to advocate for these things, and we continue to build a lot of bipartisan support. The ICA has had a different vision of how to prioritize the specific topics or needs that the profession would benefit from. And for our bill currently, it's a scope specific advocacy. We want our full scope within the state for the status of a physician, with other parameters included. But the AC has never been against opt out, which is the other main topic. And so having some discussions with ICA now around where in the past we might have disagreed on the approach or the topics and how to feature them. I think internally we're getting closer and closer to understanding one another and our perspectives. And in reality, we agree on so much of this, and we know that the profession needs a win. We need to get legislation passed to modernize Medicare. And as it stands, we have HR 539 that we're working on, and hopeful that if we can get Congress to do something, and that's the caveat, it's the least productive Congress in history. We're still waiting on them to act, but we're getting signals that there's the potential that something on healthcare can move. And if that's the case, we have one of the bills. It's a bipartisan bill with with more support than almost any other healthcare bill that's bipartisan. So we have a very good opportunity to work this into committee markup and get it rolling forward so that we can see this important change for the profession. We've just been working on this for so long.
So you mentioned the number of representatives that we have. What was the number?
152 as of today.
What
Yeah.
what do we need to get to?
Well, there isn't a magic number. There's a number that I think if it reaches 219 or 20 or maybe somewhere in that range, or 290, I can't remember exactly, but it's required to have a hearing on the floor, for instance. But if you're, paying attention to Congress these days, they don't legislate that way any longer. The expectation is not that this bill would come before the House on the floor for debate and then be passed as a single item. What we would expect is how they typically legislate now is through larger mechanisms. So reconciliation happened last summer. There are omnibus options that can happen. They've used continuing resolutions and been creative with those to add new things. But ultimately, if there was some sort of an omnibus package wrapped around healthcare that included multiple bills, ours could be one, or if there was enough momentum to get another reconciliation bill, through this session, then we'd have an opportunity to be included there as well. So it's really those bigger must-pass vehicles that we want to be included on, and so to be considered, the more co-sponsors, the better, and that's been something that at the ACA we set a new record just last January at our event for our fundraising for our PAC. We're very strategic in the way we use those funds. But I've shared with other audiences at Parker and elsewhere more recently that if you're not someone who's an ACA member, or you haven't engaged with ACA or ICA or any other association, but you happen to have a relationship with your representative Congress, just let them know that Medicare chiropractic is the most important issue to you, and then give their campaign some money, whatever it is you can afford. But if you're willing to step up and contribute and make them aware of this issue, so that when the time does come that something's moving forward, they'll understand that you're their constituent and this is an important issue to you and they should support it. So there's lots of ways to get involved in this. It doesn't have to be an ACA only thing or even ICA only. You can engage with the process at your local level as well, and you just have to let them know that this is an important issue to you.
Yeah. I have expressed my frustration over the years at the number of people that support state associations and even the national associations. And I forget where the numbers came from, but it's something like 25% only about 25% of the profession belong to ACA or ICA. I think it's somewhere in that ballpark. And I was really surprised that state association level participation, while it varies from state to state, it runs around 50%. And so I want to ask you the question, why do you think it appears as if our profession just won't get involved, won't join an association? Is it they felt like they got wronged at some point, so they don't want to donate? Is it out of frustration? Is it out of what do you think the driver is, and how do we change that, Kris?
If I knew the answer to changing it, I definitely wouldn't have time to talk to you, because this is an issue that's faced across all membership organizations. So this is a common concept for me, is that as chiropractors, we're hyper focused on the things that affect us, but broadening our aperture and including, if you're just talking about healthcare, understanding the whole healthcare environment. And if we're talking about membership associations, not just talking about our professional associations, but understanding that membership of any organization is decreased significantly over this generation. And so, I don't know what drives that. Personally, I'm a member of the Lions Club International and my local Lions Club. My wife's been the president of our church board, and other she's on the youth football program board of directors here as well. So there's just something, I think, with people and their willingness or interest to participate and contribute, that I don't know if that's not instilled in people as much as it used to be. But I do think it comes down to whether or not you feel like you have something you can contribute. If you think that you're contributing to something worthwhile, and that's something that in our state, it's a common phrase that we want work that's worth doing. So we're not afraid of work. We just want to make sure that it's worth doing. And I think for me, when I talk to non-members, what I'm really looking for is trying to figure out what their pain points are, and then helping connect what we already do to some of that. And what I love about my experience with the Lions Club is when they onboard you, they talk about leadership, and they talked about when you get a new member to your club, you find out what they're passionate about in your community. It could be something the park down the street, it could be an event or a fundraiser, but you find out what they're passionate about, and then you put them in charge of something, and then you put the support of the club behind them, and you get that buy-in because they're doing the work along the way. And so I wonder if, to some extent, it's easy to rely on the experts, the people who have been there and done that in your state association, especially. And I still get a lot of emails and go to a lot of meetings on behalf of my state association, even though I'm long off the board. And there's a little bit of frustration in that. And I am worried sometimes that I do too much for the board and don't ask someone else to get involved. And I think that's what it takes. It's just connecting new people to the work and helping them realize that we're all here to win. We want to have success for the profession, for our patients, and we want you to be successful in your role too. But we can't, if you've been here forever, we can't all just put it on the shoulders of a few who've been productive and have had success. You need to share that success with others and get them involved in it so they have that buy-in and stay.
Yeah, I can remember back to the days when I ran our state association and many years prior to that, um, when a new doctor comes into the state, I think the most likely time to get them involved is the day they get their license or the day after. They got time, and unless they walk into a busy practice day one. And I know in some states, the bylaws of the associations really don't encourage new practitioners to get involved. It's like, no, you got to. It's like my folks. They moved to Yazoo City, Mississippi, home of Zig Ziglar. If you want to frame a reference, actually, his sister was my next door neighbor. But when they moved to Yazoo City, they must have lived there 25 or 30 years, and people would still say, "Now, y'all aren't from here, are you?" It's like they never really welcomed them into the fold. And, I think sometimes if we're not careful with associations and how quickly we let new people get involved, then it's looked at, oh, that's the old guard. They're running everything. There's no way I can have any impact. And it just, it is what it is. So if you're not encouraging involvement from day one, you're actually discouraging it. And so I'd love to see that happen in all the states where the new docs are being groomed from day one and getting involved and see the importance of the association. And, maybe that'll change over time.
Hope so.
So what advice would you give to a young chiropractor who does want to step into leadership?
I think the best thing is to show up.
Amen.
That's you're going to be voluntold if you're willing to show up and speak up. Don't be shy about sharing your opinion. Read the room, but at some point, if you have concerns or you have a viewpoint, don't be shy. You're there for a reason, and but also understand that you need to learn from everyone else who's in the room as well. So for a lot of different reasons, the ideas you may have are probably not new, but maybe they didn't have an opportunity to move forward on them, and you might be that opportunity. So show up, be willing to speak up, but also be prepared to listen and have respect for people who've been there before, and ultimately have the confidence to share the pain points you're experiencing in practice. Because if you're new in practice, we all know the things you're messing up. We know you don't know how to bill. We know you don't know how to code. We know you don't, especially if you're running a practice on your own from scratch on day one. We know you don't know what you're doing. It's okay. You have the confidence to come forward and admit that. It takes a lot of confidence to be able to come forward and admit when you're struggling. But that's what the state association's for, especially. And at the national level, if you've been able to come up as a student into those rooms as well, the similar advice holds is just show up and share your ideas and pain points, your perspectives, listen, and be prepared to help. So that's the best advice I can give.
Yeah, I did a presentation a year or so ago for, I think I was in Illinois, and the presentation was just say yes, meaning, and I told the story when I went into practice, you may have heard this on the other podcasts, I couldn't get any cooperation with the medical community, so I literally sent out 500 letters to all the MDs in my city, home of University of Mississippi Medical Center, and I got one call from a doc that said, "I don't know who the hell you think you are sending me a letter about why I ought to be working with you." But I also got calls from University Medical Center to ask me to speak to the neurosurgery residents, to the pain management residents, and then the orthopedic group. And, it literally, I will tell you, I'm 30 something years old at that time, and it scared the bejeebers out of me. What am I going to talk to these guys? And I realized they don't know what the hell we do. I'm the expert in the room on what we do, and to the degree that I was willing to step out of my comfort zone, I mean, literally, that is what built my practice and ultimately led me to the point where I'm partners in a spine center with the campus of it with 13 MDs. I mean, it happened out of that frustration, um, but it changed because I said yes every time I was given the opportunity. And if you say yes often enough and you show up, literally it can change the trajectory of your practice. So, Kris, from your perspective, your perch, where do you see us in 10 years in the broader healthcare system?
The broader healthcare system, I really hope we're at a point where we're integrated in all different settings. So, the Medicare legislation especially is going to be critical for integrating in hospitals. Right now, as I mentioned, in a community health center model, it's just more amenable as a business to what we do because it's not relying on fee for service exclusively. So, I hope there's some evolution in the way care is delivered and that we're able to identify, objective outcomes that people can agree upon for specific conditions that we have a lot of success with, and people start to understand and rely on us as the experts we are for those patients, and that we can not necessarily have to go and work in a hospital, but have systems set up with our EMRs and other resources for communication purposes, so that I may not be in the same four walls as the hospital or the clinic down the street, but I can operate in an integrated way from my practice. And I'm in routine discussions with the different vendors that we have in our profession, and they're trying hard to help solve some of this too. Uh, but I think ultimately, just being able to operate in that ecosystem without having to become part of it or within it would be a success for healthcare across the country. That more broadly, I think we have a problem in healthcare that we all know, and in my experience, there's still never been a better time to be a chiropractor. I'm not sure there's been a worse time to be in healthcare providing services of any kind. I think there's so many external pressures that we face now, and reimbursement's only part of it. But more and more, we're being told how to practice by people who own our practices, and that's across healthcare. That's not just us as
Yeah,
chiropractors. So I think
consolidation.
restoring the autonomy and decision making to the people who have a license, who sit knee to knee with patients and deliver care. That is my hope, is that we can restore that some common sense to healthcare. And then, you know, honestly, I really hope there's just a day when I can just go to practice and see my patients and not have to do any of this extra stuff because we've solved all these problems. But or someone else
Well,
has stepped in.
maybe for the next or the generation after that, you're laying the groundwork for
Yes,
them. I get it. Yep. Overall, my goal is to leave it better than I found it. And that's just a driver. So I got some just for fun questions. You ready?
I'm ready.
Who's your hero and why?
So I consider myself extremely fortunate that my parents are my heroes. My dad's a family practice physician in internal medicine, and he's been practicing in the same rural community in southern Iowa for the last 45 years, basically. And my mom was in charge of raising my sister and I, and she was uh, involved in the community quite a bit. She was Citizen of the Year one year for the project she worked on, and so I think, as I mentioned before, that instilling a sense of service and others, through others, I think that was something my parents did very well and continue to be a great example of, and that's why they continue to be my hero.
What talent do you have that most people don't know about?
I'm not sure if I have a hidden talent at all. I think I'm kind of boring. I really like this stuff. this is this is my work and my hobby. And then at home we have four kids that are busy with all kinds of stuff. And so I guess I have become a pretty mediocre ranch hand.
Yeah.
So my wife grew up on a horse ranch, and so that means I live on a horse ranch, and that means I had to learn how to do a lot of different things, from building fence to feeding animals to fixing fence and buildings,
Yeah.
and especially through a North Dakota winter, that's tough when you have animals living outdoors. So I
That can
maybe
also
my
go
yeah,
ahead.
well, maybe my hidden talent is just I'm adaptable. I've been able to continue to adapt to new things over the years.
It's just as a side note, it's interesting. There are things that just take our mind off of everything else because you're focused on what's right in front of you. And there are times that I'll just decide to do the dishes at the house. My wife says, "Don't do those, Ray. I'll do that." And I said, "No, I need to do the dishes." Because all I got to think about is, you, you just can really compartmentalize down to what's right in front of you. So that's called therapy, not work. Okay.
Yes, yes.
One last question: what's the worst job you ever had?
Well, I mean, I've had to do a lot of stuff as a mediocre ranch hand that I haven't been thrilled about. Throwing hay to horses in 40 below with the wind howling is at the top of that list. But I will say, when I was going through my last year in chiropractic school, was I took a job at Starbucks as a barista, and I'd show up after clinic in the evening, and mostly I would just wash dishes. But what I also had to do was clean the bathroom, and that experience, I think everyone should
Unbel-
have to clean a public restroom for 1 week, and I think that would make the whole world a better place, because there's just something about having to do that humbles you. But also, if you take it seriously and do a really good job, you can find value in really any type of work, and I think that's a real a value that I think turns a bad job into something positive.
yeah, it's all about the attitude. Well, doctors, if you're offering discounts in your office, make sure you're not violating state or federal rules on dual fee schedules, inducements, or anti kickback laws. The fines are no joke. Our profitable discount strategy keeps your discounts fully compliant and profitable. It all starts with a free, no obligation call to see if we can help, just like we have thousands of doctors nationwide. Many of our docs have seen a 20% increase in revenue and a 50% retention of patients year over year. For over 18 years, over 7,000 chiropractors have helped 4.3 million patient family members get affordable care through ChiroHealth USA. If you want more revenue, better retention, and peace of mind, call 888-719-9990 or visit CHUSA.com, that's CHUSA.com, to see why ChiroHealth USA is the network that works for chiropractic and you. Make it a great day. Kris, again, really appreciate your time, sir.
Thank you, Ray.
All right. Have a good one.